Hello everyone, this is Fire Chief Paul Dow with Albuquerque Fire and Rescue. This podcast is designed to bring you helpful training and best practices and some additional resources that you can access from anywhere. So thank you for joining us and enjoy today's episode.
Alarm to Rescue 15 is 15, Rescue 15, Engine 15. Respond out to Cliffs Amusement Park. It's going to be near the Sea Dragon. Got a 15-year-old male, the tracheostomy. He's having trouble breathing after getting off the ride. The 6 Delta, Rescue 15, Engine 15. Cliffs Amusement, 6 Delta 2, 15-year-old male near the Sea Dragon.
Hello and welcome to another episode of the AFR podcast, joined again by Dr. Pruett.
Hi, Andrew.
Hi. So you heard the dispatch. We do get called out to tracheostomy emergencies, and I maybe have seen 2 patients with one of these in place, but Dr. Pruett has a horror story for us to make sure that we're listening up close on this episode.
I'll be completely honest. Tracheostomies are one of the things that scare me, and they shouldn't because it's the ultimate definitive airway, right? But sometimes things can go terribly wrong. And
I didn't even know that I should be afraid, but I probably should have been this whole time.
Yeah. So they do scare me. They shouldn't, because we can make them fairly simple, and hopefully after this podcast we will. But I think over the thousands of patients I've seen over the years, one of the worst things I've seen is a tracheostomy that was bleeding. And we can get into the pathophysiology of that a little bit later, but this lady came in, and she came in by ambulance, and she had been just having a little bit of dried blood around a little 4x4 around her tracheostomy site. And I was a resident at the time, so I thought it wasn't that big of a deal. She sat in the ER all night waiting for the ENT to come evaluate her, the surgeon who had placed the tracheostomy, who she came to see, but she was stable, so we just let her sit there for hours. No bleeding while she was there, dried blood on a little 4x4, not much to mention. And when the surgeon got in there, he had cleaned around the trach site and said it was okay, and then he left to go get his supervisor. And shortly after that, I was paged emergently to the room, and this lady had just massive amounts of red splurting blood coming out of her tracheostomy site. And she was getting more and more tachycardic, hypoxic, blood everywhere, and just getting pale, and that terrified look in her eyes, like right in front of me. And so we had to act really fast to troubleshoot the problem. It was pretty terrifying for her more than me, but it was an awful experience all the way around.
All right. Well, that'll be our teaser. So if you want to know how to fix that patient, stay tuned until the end of the episode. Okay. So again, this is going to be part of our respiratory emergency series that we're doing. This is just another thing that could go wrong. As you heard on the dispatch, this crew got called out to a 6 Delta Cliffs Amusement Park. One of the things I wanted to mention about this dispatch is it shouldn't be that mysterious. It shouldn't be like, I don't know what the problem is. These people are probably going to have a caregiver, so they're going to, as you heard on that dispatch, they knew there was a trach in place, so that part shouldn't come as a surprise. But again, it's not very common. I've only run across it a couple times. You probably see it a lot more. Again, with all the patients in the city coming to the ER, you're probably exposed to it a bit more than we are.
Yeah, I think the good thing about trachs is you're right. There's usually a caregiver there, and more often than not, they're very highly trained in tracheostomy care, so I tend to depend on them to answer questions and help troubleshoot things with the trach, because they're very reliable and they're very highly trained.
I guess my first question is, what kind of patient needs a trach? Why do they have that in place?
So I think of usually about 3 things that usually a patient will get a trach for. A lot of times you'll see it in your patients that need prolonged ventilation, like a terrible spinal cord injury or a terrible brain injury or even a stroke, where you just can't get them off the ventilator for whatever reason. They don't have their own respiratory drive coming from their brain or their diaphragm, and they're going to need long-term ventilation. There's some patients that have an obstruction in their upper airway, so whether that's cancer or swelling or even morbidly obese patients, for whatever reason their upper airway is not functioning and they need to have a more permanent way to oxygenate and ventilate, would be another type of patient that would need it.
Okay, and then when we're looking at these trachs, you have a PowerPoint on this that you break it down into the what, when, and why. So explain those 3 questions that we should be asking ourselves.
So as you're approaching this patient and you're on the way to Cliffs Amusement Park and you know you're going to be dealing with a trach, the 3 most important questions that you're either going to have for that patient or that caregiver are going to determine your way that you're going to address the shortness of breath complaint. So the what is, what kind of surgery did you have? So some patients will actually, like we talked about, just stroke patients, will have a completely intact upper airway that works just fine. It's just they don't have the mechanics of breathing or they're aspirating too much, so they have their trach placed. But there's other patients that have a surgery that's called a laryngectomy, where actually their entire upper airway, all the anatomical structures in their neck have been removed, usually for cancer. And what the surgeons will do is take that lower part of the trachea and just divert from the upper airway and literally just pull it to the front of the neck. So there's no access from the mouth to get to the airway. And that's very important when you're thinking about having to try to ventilate this patient. So that's the what. And then the when is also important because you want to know how fresh is this trach, how long has it been in place. If it's less than 2 weeks old, this is not an airway that you're going to want to manipulate in any way. You're going to do your best to do blow by, but you're not going to want to stick anything in it because there's a really high risk of creating a false trach. But if it's been there for a while, then you can feel fairly reassured that that's a trach that you can work with and manage.
Okay. Can you explain a false trach? I don't think people are going to be as familiar with that as you are.
So a trach that's less than 2 weeks old, those tissues are going to be really soft and really friable, and there's not kind of a, if you think about someone who's got their ears pierced and they have those what's that called?
Gauge.
A gauge in their ears, and that trach is there and it's been there a while and you can stick anything through it, right? And over time it's been expanded. That's kind of like a trach. It just takes time for those tissues to heal and be able to take foreign bodies like a tracheostomy going in and out of it. Whereas if it's new, the tissue is so soft and there's lots of tissue planes that if you were to stick something in there, that scar tissue hasn't been formed and it would be harder to get something actually in the airway and would be easier to get things in the neck where they don't belong.
Okay, so the tube's going in and it seems like it's going in the trachea, but it's not actually going to provide effective ventilation.
Yeah, and it's actually more dangerous for the patient because it'll create, more blood, more trauma, more swelling, which will be even worse for the airway. And so really, if it's less than 2 weeks old, even myself, I would just prefer that people just don't touch it and just try to passively ventilate through the hole that's still there if the trach comes out. When
you bring up those false trachs, it reminds me of when I was, again, in the military, we got to do some live tissue labs. So they would have you try to do a crike on a pig, and they've got all this neck fat, and then so you have to cut through all that neck fat, and then once you get down there and you puncture the cricothyroid membrane, once you go to insert your tube, if you kind of don't keep a good placeholder on that spot, you'll end up sliding the tube through one of those false trachs. So the tube's going in, but it's not actually, when you go to bag, it's not actually filling up the lungs with air.
Airway. Yeah, it's very easy to do to end up outside of the airway and inside the other neck tissues where you don't want to be.
Okay. All right. So that's 3 questions you're going to ask. What, when, and why was it placed? So let's get more detail. Let's look at these parts to the trach. So if you're watching on YouTube, we've got some visual for you. If you're listening, we'll try to describe it. What are the 3 parts we need to know about?
Okay. So this is the tracheostomy itself. What is valuable about this, or the things you want to look at, are it's just like a ET tube that's shorter. So you want to see if it's got a balloon cuff, just like an ET tube. Some will have it, some will be uncuffed, and that's going to help determine whether or not the patient can phonate through the vocal cords. But you want to know if there's a cuff there. The other thing that's helpful when you're looking at this is there will always be the size listed on the front, so you can ask them how big it is. That's important to know if it comes out, or important information for the hospital too, so you can tell them if they need to replace it. This one in particular is a size 8, and it's actually the same size as a 8.0 ET tube.
Okay.
So the sizes are standardized. Each trach will have an inner cannula. that goes inside. And what this is useful for is this is the piece that can attach to either a BVM or a ventilator. So you're not going to be able to bag a patient unless the inner cannula is in place. There's pluses and minuses to this. This will help you ventilate if you need to, but the other thing is, if you notice, it's pretty thick plastic, so it almost decreases the diameter of your airway by half. So if you've got somebody who's having respiratory difficulty, it's easy for this to get plugged with either mucus or secretions or whatever. So one of your first moves when you see this patient who's having respiratory difficulty, and this is the only airway that they have, take this out for a minute, inspect it, make sure there's no plug on the end that's making it hard for them to breathe. You can kind of wash it out or clean it off and then put it back if you need a bag. The other thing is this is an obturator, and it's basically like a stylet for your tube. So if the trach had come out and there's no caretaker or anybody there to help you get it back in, and you feel like you absolutely have to, and it's an older trach that's been established and has been there for a while, you just put the obturator in just like you would a stylet, and it just adds some firmness. And the actual reason for it is because it's very soft at the end, and like we talked about those tissues in the neck, it doesn't tend to dissect tissues. It's blunt and it's smooth, and it tends to just help the trach guide right back into where it should be. The important thing to know is if you're using the obturator, obviously it's a solid piece of plastic, so it's occluding the airway. So you use it to put the trach in, but as soon as you're in place, you've got to take it right back out so you can ventilate.
Okay. Can we go back to the cuff versus uncuffed? So yeah, sometimes you're saying phonate, just that means talking?
Talking, yes. Sorry.
Okay, so if which one would allow somebody to speak?
So if you have a patient with a cuffed trach, this patient is not going to be able to speak, because the normal way that we get our sounds made is through air coming up through the vocal cords, and this cuff will completely occlude any air from coming above the cords and out the mouth. So if the cuff is down, or there's special trachs that don't even have a cuff, or special things that you can put on the end to help the patient speak. But if you see that the cuff is up, the minute the cuff is up, that means you're not going to be able to verbally communicate with your patient, or they won't be able to verbally communicate with you.
Okay, so if there's no cuff, they would be able to like put their finger over the hole, and that way the air is going out through their vocal cords, or there's a one-way valve where they can breathe in through the trach, and then when they exhale, that's going out through their vocal cords again, allowing them to speak. Exactly.
And so the patients that usually can speak are the ones that are less reliant. They're more reliant on the trach for an airway and less reliant on it for positive pressure. If this is a patient we have to bag, for whatever reason, say they're in respiratory failure, it is good if they had a cuffless trach, air can leak around it. So if they are in respiratory distress and you have to bag them, it's good to inflate the cuff, because more air is going to be going into the lungs where you want it to go than out the upper airway. Does that make sense?
Yeah.
Okay.
All right. And then another part I wanted to bring up with these trachs is, what is bypass, like normal ventilation that you and I are doing? What are these patients bypassing?
Yeah, so I think we tend to take it for granted, but there is a ton of value to having your upper airway intact and using that to help with respiration. The sinuses and the oropharynx, the mouth does a really good job of humidifying and cleansing air that comes in. It warms it as well, so that it catches a lot of the particles and things that would cause irritation in the lungs. And if you take that out of the equation, it causes a lot of problems in the lower airway, which leads to some of our trach emergencies.
Okay, so there's, not as clean air going in, and then they're also not able to get all that up as effectively, right? Because their glottis is bypassed, so the coughing is less effective as well. Is that correct?
Absolutely, yeah. So if you think about when you cough, you kind of close your mouth and you get an extra burst of pressure kind of in the back of your throat, and if you don't have the ability to create that pressure because you have a hole in your neck, you're not going to be able to cough very effectively, and you're also going to be having more mucus made, because the cilia in your nose, the little hairs in your nose that kind of catch all those little particles, you don't have that, so you're getting particles directly into the lungs that your lungs are trying to cough out, but you can't. And so that's why these patients tend to develop a lot of mucus that's really sticky, because it's also not humidified or warmed.
Okay. All right, so we just talked about all the parts of the trach. Now, what can go wrong?
I always try to keep things simple. So there's three main things. Obstruction, bleeding, and then dislodgement. And there's a easy way to approach trach emergencies, the DOPE's mnemonic.
Okay. And that's, I haven't heard the S before, but I know at least DOPE, for an ET tube, they would bring DOPE up a lot as like troubleshooting it, what could go wrong. So what is that mnemonic going to be for us?
Okay. So DOPE's, you're right. Like it works for ET tubes. It works for trach, any kind of airway that you have in place, but the tube could be dislodged. It could be obstructed. You also need to think about anybody who's getting positive pressure. It could be too much pressure causing a pneumothorax. Could be an equipment failure, and it could be a problem with forced ventilations versus the patient's respiratory rate. So stacked ventilations might also be a problem as well.
Okay, so stacked ventilation is like when the patient's trying to breathe over the ventilator.
Over the vent, or there's some kind of asynchrony between the two, and it makes it hard for the patient to either exhale or inhale when they want to.
Okay, so that's a general, mnemonic if you need to go back to have some kind of way to remember everything. But what in your experience, what are the three most common things that we might run into in the field?
The three most common trach emergencies, and far and away the absolute most common, like probably 85% of the time, is going to be mucus plugging or some sort of obstruction because of what we just talked about with the lack of the upper airway and all that provides. The second most common will be some sort of dislodgement, so like either the trach came out or it's malpositioned in the neck. And the third, and thank God it's like pretty infrequent, is the bleeding.
Okay. So yeah, the most common one, let's talk about having that inner cannula all plugged up with mucus. What are we going to do on scene with that?
Okay. Like I talked about, like probably my first approach would be to take the inner cannula out, see if there's a ton of mucus in there, or even just sometimes it's as simple as a plug on the end, or some sort of concretions is kind of a descriptive term, but you can have basically build up inside the inner cannula that you can just wash out. And then you can, if it's not an inner cannula problem and you still think there's some obstruction through the trach, you can suction through there as well.
Okay.
And have you had to suction one of these before?
I've never suctioned one, no. So
okay. What
do we need to do prior to? Do we just stick our French catheter down there and suction?
So we talked, these secretions are going to be super thick, and so one thing you can do to help yourself would be to loosen them up. It'll make them easier to suction, and so you can put anywhere from 3 to 5 milliliters of normal saline from a flush in there, and have, before you do that, obviously you're putting fluid directly into the lungs theoretically, and so you want to be able to suction that out pretty quickly as well. So have your suction set up. You want to use a flexible little tiny French catheter. Put your fluid in. Let it sit there for a minute or two to kind of hit those secretions that you're trying to loosen up, and then be ready to suction it back out. Okay.
And there's some, with everything, it's like so easy to say, go ahead and suction the patient. But as I've learned, in my career, there's always things that go wrong with everything that you try to do. So I'm just going to spend a minute talking about our suction. So, prior to, when you're doing your truck checks in the morning, you got to check that suction pretty thoroughly. You got to check the batteries. Most of the time you got the yank hour set up already attached to the tubing or right there easily connected. But the French catheters, most of the time they're stored in the little zipper compartment. So we got 3 different sizes of French catheters available. There's a little pediatric valve that you can pull out. So it's a white valve on the side that if it's like suctioning a ped, you're going to want to have less suction. So you can pull that valve out. And one time though, we still weren't getting the suction that we needed, and I tried to troubleshoot it as much as I could. And what the problem ended up being was the container inside of, you have the red outer part, and then you have like the little container. When you pulled that out, there was like a little crack in there. And so that was preventing like a good seal, and you weren't getting the proper suction. And so now it just adds to your checks. So now when you're checking your truck, make sure you don't have a cracked container, or else you're not going to have suction when you need it. So.
Oh man, that's good. Those are super helpful tips. One other thing you might be able to do is, because this is a frequent problem with trach patients, is those caregivers are going to be pretty facile at suctioning these trachs as well. So the patient might have their own, if for whatever reason your suction isn't working, there's a good likelihood that these patients will have their own suction pretty readily available as well. One thing I didn't mention is when you're suctioning and you're putting that catheter in, you don't want to go too far. So I wouldn't go much more than 2 or 3 inches inside the stoma with your catheter, because if you go too deep, you can like stimulate a vagal response and the patient might brady down.
Okay.
And you can cause some bad effects that way. So don't go too deep, but go deep enough to get the suctions out, or the secretions.
Okay, so that's the most common problem. These cannulas might be just full of mucus, so take them out, clean them. If you have to do more of a deeper suction with the French catheter, do that. And the second problem you mentioned was the trach might be misplaced, or it might even fall out. So what should we do in that situation?
So this can be a problem too. My first move, it comes back to your what, when, why questions. If the trach is old and it's been established and you know that it's older than 2 weeks, I would ask the caregiver. Usually they're going to be the best ones at replacing the trach. Ask them if they've tried, if they can, and I would let them do it because they're probably more experienced at it. But if you need to, it's okay to go ahead and replace that trach if it's been there a while. Then some things that do happen, it might just need an adjustment. So it could be if the back of it is just malpositioned and say it's butting up against the posterior wall of the trachea, it might need to just be advanced a little farther to make sure that there's a patent opening there to get air in and out. So it might just need an adjustment. If it's all the way out, ask the caregiver, or if it's old enough, you can go ahead and put it back in yourself. Just make sure you're using the obturator, and it might take a little bit of lube on there too to slide it back in, because this can be kind of painful when you have to put it in.
Okay. Yeah, if they're on a ventilator, so I don't know if we touched on it yet, but you want us to, there's some kind of breathing problem going on, patient's on a ventilator, you want us to disconnect from that ventilator?
Yeah, that's usually the best thing. We talked about like the breath stacking, and maybe it's an equipment failure that's leading to their respiratory distress. So if you just take the ventilator out of the equation of what could be causing their shortness of breath, it's pretty easy to just use the pieces that are already there to bag and then troubleshoot from there.
Yeah, and throw your capno on there too, because that's going to tell you some information. If you're not, if you're seeing a good waveform, then it can give you some more information.
Help guide your treatment. Absolutely.
Yeah.
Absolutely. I just wanted to touch on new trachs. So let's say you do get the patient who's in respiratory distress with a new trach that came out. What do you do if you're in that situation? And I know it happened at Rescue 16 last year. There was a lady who had a fresh trach, and she actually was having an anxiety attack, and it was only a week old, and she just pulled it out. And that subsequently led to her having a respiratory arrest. And the lieutenant on scene did a fantastic job, but it was a new trach. And he knew that he probably wasn't supposed to put that back in, but that was the source of her respiratory arrest. So what he did, and what I would advocate only in that instance where your patient is arresting, is use a bougie, because it's soft enough. And just like you would with a crike, put the bougie in, do your best to do it gently and get it where you think that airway was, and then put the 6.0 ET tube over it, just like you would for a crike, and confirm with all your normal things, capnography, breath sounds, chest rise. But yeah. So
awesome.
That's he did a fantastic job.
And then what do you think about, if it wasn't a laryngectomy and there's still some upper airway anatomy, what do you think about like a BVM option?
So if the upper airway is an option, you can always use that. If you want to try to intubate, you want to use the LMA. Even CPAP is good, because a lot of these patients will need like positive pressure. The only thing to remember is they have a hole in their neck, so you're going to need to seal the hole somehow if you are going from above. And I had one of these patients in the hospital just a couple weeks ago where we did have to intubate from above, and she had an air leak, and so we just put a tegaderm over the hole in her neck, and it worked just fine.
Okay, so same as like a sucking chest wound, just some kind of occlusive dressing is going to be able to cover up that stoma.
Mm-hmm.
All right, and now let's now for the cliffhanger. We've been having everybody hang. If the trach is bleeding massively, like in your situation, how did you end up dealing with that? And like what? I guess before we get to that, what was going on? Where was all that blood coming from?
Okay. So ends up what happened was tracheostomies that have been in place a long time, if they're placed a little bit low or the patient has had radiation or they have tissues that are more friable than normal, right below where the end of the trach sits is a branch of the aorta called the tracheal innominate artery. It's actually the innominate artery, and it butts right up against the trachea. And if that tissue is eroded, very rarely this happens, but sometimes you can get that blood coming straight off of the aorta at super high pressures that can erode into the trachea and cause this massive kind of bleeding. And that's probably the most feared complication or tracheostomy emergency that there is. And the mortality is off the charts. I think it's like about 14% of people survive this. So it's a really bad thing. Thankfully, it happens pretty rarely. Your steps first thing to take away is any kind of bleeding. Even this lady, she just had a little bit of dried blood on a 4x4. Take that seriously and realize that it could be like an indicator of impending problems. So if you see it, take it seriously. Get your large bore IVs, keep a close eye on it, and try not to manipulate that trach. Now, if you get the massive bleeding, there's 2 steps. The textbooks will tell you that there's 3 steps to handle it, but really, I found that there's really only 2. Your first step can be to overinflate the balloon if it's a cuffed trach. It all comes down, it's simple bleeding, right? It always comes down to direct pressure. So you want to use what's already there to do direct pressure if you can. So you overinflate your cuff and try to maneuver your cuff to where it'll be pushing against wherever that hole is. If that doesn't work, and you'll know in about 10 or 15 seconds, then just pull the whole thing out. And what we ended up doing was putting our finger in, and and this is on my slides, but usually it bleeds right behind the manubrium. And you can put your finger in the hole and just pull that artery and use that bone there as kind of a source to provide direct pressure and tamponade.
Okay, so manubrium is the very top of the sternum?
Yeah, it's that solid bone right up at the top, right where your ribs come together. And what you can do, this patient will be choking and gagging and coughing. And so you can try to either do supplemental oxygen from the nose and the mouth. We had a non-rebreather, high flow over her, and I also put a nasal cannula on the side of my finger, high flow, so we could go get her some oxygen directly to her lungs. And in the meantime, you have another set of hands that's trying to suction the blood that's coming out. So a lot of things going on in a little tiny hole. But she ended up actually surviving, and she made it. We had to ride the stretcher with our finger in place up to the operating room, and they were able to repair it surgically.
Wow.
Unfortunately, it did occlude because of the direct pressure for so long. It occluded her right common carotid, and so she had a stroke as a consequence. Wow. But she didn't bleed to death.
Right.
So.
And I'm surprised that with your finger in there, that they're still able to get some air by, like you're saying with the cannula. So.
Yeah, we use the little tiny prongs to kind of squeeze around, and then she still had an upper airway patent too, so I think the non-rebreather from above helped a little as well.
Awesome. All right, well, hopefully it doesn't happen to anybody out there, but now you know what to do if it does.
Yeah.
Thanks for listening. Hopefully you're a little bit more familiar now with a trach if you do run into it out there in the field, and hopefully it's more of just a simple cleaning out that inner cannula. So all right, everybody, thanks for watching, and talk to you on the next episode.